Hi all, this is Jess, and I am recording some information about cholelithiasis and cholecystitis, gallbladder problems, chole. I'm going to share my screen. There'll be several chapters about this, so I'll be breaking the video up into smaller pieces, just to let you know. And let's share the screen so that you can see what's going on. Great. All right. So cholelithiasis, gallstones. Cholecystitis, inflammation of the gallbladder. So cholelithiasis is most common disorder of the biliary system. The biliary system being the liver that makes bile, and then it gets collected in the gallbladder for use at a later time. When the digestive system encounters some fat, the bile is released from the gallbladder and enters into the duodenum. And there ends the pathophys list, or the A&P review part of the day. So cholelithiasis, when that bile is hanging out in the gallbladder, sometimes it gets sludgy and sometimes it develops stones. Cholecystitis is inflammation of that gallbladder, usually because there's stones in there. It is a common health problem. There are several risk factors for it, such as being a lady, or being female rather, having multiple children, being over 40, if you've had estrogen therapy, if you've had a sedentary lifestyle. It tends to run in families. It tends to be in overweight people. And anecdotally, sometimes it's associated with the keto diet. So sometimes that keto diet is being used by obese people to be able to help them lose weight, and it comes along as part of that symptomology too. So loose correlation more than anything, not a causation. So throughout the slideshow, you'll see that there's the case study slides that are embedded. So every now and again, we'll have a case study slide. And so AL is a 45-year-old mother of 3 who presents to the ED. She has acute abdominal pain in her right upper quadrant. Hallmark sign of gallbladder problems, BT-dubs, that acute abdominal pain in the right upper quadrant can also travel. And there are people who come in with gallbladder problems who sometimes they're thinking they're having a heart attack because they have such chest pain. It can even radiate up to the shoulder. But we'll talk about that in a little bit. She has she rates the pain at 7 out of 10. She's 5'3". She weighs 170. She works as a florist. She doesn't exercise. Out of what we know, what does she have for risk factors? I'll give you a pregnant pause here, excuse me, and let you think about those, and then I'll keep moving. Alrighty, so etiology, pathophys for cholelithiasis, gallstones, big word for gallstone. There is no real known cause. They do develop when there is a balance gets disrupted between the cholesterol, the bile salts, and the calcium. So a body chemistry problem has this gallstone problem happen. Bile secreted by the liver is supersaturated with cholesterol, and then because that bile is hanging out in the gallbladder, that can lead to supersaturation again, which makes a biliary sludge. So it makes a super concentrated sort of thing. Immobility, pregnancy, or inflammatory or obstructions in the biliary system, decreased bile flow can have this happen too. Stones can stay in the gallbladder. They can also migrate into that system, cystic or that common bile duct, that little duct that goes in between the gallbladder and the duodenum. And then it causes a lot of pain as it goes through the ducts. It can even cause a complete biliary obstruction if it gets lodged in that duct between the gallbladder and the duodenum. There we go. So cholecystitis, that was cholelithiasis. Cholecystitis, itis, inflammation in the cholecyst, in the gallbladder, and in that cystic, or that duct. It's most often that inflammation is caused by obstruction from stones or from sludge. You can have acalculous cholecystitis. And that's usually happens in older adults. It happens in critically ill peeps. Prolonged immobility, fasting, prolonged parenteral nutrition, IV nutrition, rather than like taking it through and digesting it into your stomach and having normal digestion. Get your nutrition. Diabetes as well. Biliary stasis, the liver is not pushing stuff through. It can also be caused by adhesions, which are little growths. It can cause cancer. It can be caused by anesthesia. Remember we were talking in pre-op? Well, maybe you haven't gotten there yet. In the pre-op, post-op stuff, we talk about how analgesia and anesthesia can slow down your GI system and create problems such as ileus and constipation. So ileus and constipation and cholecystitis. As well as opioids can slow down the GI system as well. So anything that has a side effect of GI slowdown can create cholecystitis. Inflammation is usually confined to the mucus lining, or it can be in the entire wall of the gallbladder. So what happens, and let's look at this picture here. I'm going to grab a pen off of the PowerPoint here. So what happens is the gallbladder develops a lot of edema in here, and edema and inflammation cause pain. It can be distended with bile. It can also, in case of infection, be distended because of pus. And the cystic duct may also be occluded. So here's the little gallstone here. Let's say for whatever reason it was small enough to get through that little opening. It can also get lodged here. They can get lodged here. They cause a lot of pain. They cause a lot of inflammation. And if for whatever reason they get lodged outside of the gallbladder, they can actually cause a huge abdominal distension because it completely disrupts the liver and all of the liver functions. And it's just, you wouldn't think that tiny little stones could kill a person. Tiny little stones that aren't supposed to be there in the first place, that are involved with the gallstone, and they make a person septic and they can kill them. So cholecystitis and cholelithiasis are big deals. Big deals. All right. There can be scarring or fibrosis after attack. There are people who have like flares and then rescindents and then flares and then rescindents. But there are interventions for that as well. So not to give away the surprise ending. So here's our case study again. What additional clinical manifestations of cholecystitis would you assess in our clients? Clinical manifestations, they can go from nothing. You might not have anything to completely like severe, like 10 out of 10, crushing chest pain radiating to the shoulder. Like I said, there's a lot of people who come in with an emergent cholelithiasis, cholecystitis situation who think they're having an MI. They think they're having a heart attack. Pain is worse when the stones are moving or when they're blocking things off, like I was drawing on the last picture. It's a steady, excruciating pain. It causes tachycardia. It causes diaphoresis. Tell me if this sounds like a heart attack. You're sweaty. Your heart's pounding out of your chest. You have all of this pain. It's very easy for a client to think that they're having a heart attack when they are actually having a gallbladder attack. And typically what happens, it happens about 3 to 6 hours after a high fat meal, and when the patient lays down. So 3 to 6 hours, we've eaten our KFC, right? And it takes about 3 to 6 hours for our stomach to digest the KFC. And so, or the French fries, or whatever it is that we're eating. If you happen to be vegetarian or vegan, maybe you're eating French fries fried in canola oil. I'm not 100% sure. Not sidebar. Squirrel. So anyway, the stomach gets done digesting, kicks it into the duodenum. The duodenum says, hey, there's a lot of fat in here. I could use some bile to help all this out. And then that triggers the bile and the bile to come down from the gallbladder into the duodenum and help break up all those fats. So if there is problems in said gallbladder area and the body is getting chemical messages from the duodenum that there's a lot of high fat and it could use some help, it's going to try and it can't get there, and then it gets frustrated and then there's pain, right? We're going to be tying human emotions to gallbladder function. In addition to the pain, you end up feeling indigestion, there's fever and chills. If there is a way that, if those stones are blocking that common bile duct, you will have jaundice, because that's how the liver excretes bilirubin, is through the bile. So if it's been going on a while, you'll have jaundice. It's not an immediate finding. It's not like, oh, I have the pain, I have the stone, I have a pain, I have instant jaundice. No, it's I have the stone, I have the pain, and then I develop jaundice after a series of time. And people don't necessarily have to have jaundice to be able or to be diagnosed with cholecystitis. They'll be right upper quadrant pain and tenderness. And it can be referred pain, which means that it might present up here in their abdomen. It might also present up in their scapula. That's just why people confuse it with chest pain and heart attacks. Nauseous, restlessness, diaphoresis. Now, in this class, we do not talk about heart attacks. We will talk about heart attacks next semester in 446. However, this is the same presentation, minus jaundice. And that jaundice is optional. Jaundice is not a mandatory, but this is almost the exact same presentation as a heart attack. So when a total obstruction occurs, and I've got my pen still turned on, so we've got a gallstone here, right? Here's our gallbladder, here's our common bile duct, here's our duodenum. When a total obstruction occurs after a while, what will happen? It's not immediate either. The kidneys will start taking over and start excreting bilirubin, which just destroys the nephrons. That's a different topic. However, so that when the kidneys are excreting bilirubin, you have this really dark amber urine. You will not have bilirubin and bile in the GI system, so you'll have these clay-colored stools. The bile salts that have built up that are now being filtered by the nephrons in the kidneys will also start getting filtered through the skin. So these people will have total itchiness if there's a total obstruction, because the skin will start filtering out the salts as well. They will have bleeding tendencies because the liver is completely, this total obstruction is basically causing an absolute liver failure. So if you have an absolute liver failure, you have all of this, as well as intolerance to fatty foods. That intolerance to fatty foods creates wicked bad digestion. And then it creates steatorrhea, which is fat in your stool. So then you'll have these fatty floaty stools that are clay colored, and your liver will be shutting down, which is what all of this, all of these different manifestations that you see listed are. Let's see. And then acute cholecystitis, you'll have inflammation markers that we can pick up in the blood, and you'll have inflammation as well, which is where the fever comes from. You'll have leukocytosis, which is a white blood cell problem. You'll have physical examination findings, including a right upper quadrant or epigastrum. That's that part. tenderness. You'll also, that stomach, because the liver is in failure and almost all of the blood flow that comes into the abdomen area exits through the liver, but the liver is not doing anything. So there's blockages in the blood flow from the liver too. It backs up into the abdomen and it creates this abdominal rigidity, and it creates a really hard, tight tummy, to use really fancy words. Chronic cholecystitis that's where if you're having like an acute, like boom, bam, bingo problem. More often than not, people will have episodes of chronic cholecystitis, and then they'll go episodic between chronic and acute. Like when they're having a flare, that's when they have this acute problem. Otherwise, they're in chronic, which is a fat intolerance. They can't handle fatty foods. They'll have a lot of dyspepsia. They'll have a lot of like that gassy sort of feeling. They'll have heartburn, and they'll have gas, flatulence. So complications, if we don't get on top of this, I kind of alluded to some of these earlier. The only reason I really have cholecystitis like way on the brain is my first client my second client that I ever took care of ever in my whole life as a nurse, once I got my license, had a gallbladder attack so bad that he was on the ICU, intubated, on kidney replacement, slow dialysis, 24-hour dialysis, kidney replacement therapy, CRRT, chronic renal replacement therapy, and we couldn't figure out why he was septic, and it's because his gallbladder was crap. So what happens is you can have gangrenous cholecystitis, where that there's an infection that caused the gallbladder inflammation in the first place, and that infection is spreading throughout the system, and it's causing sepsis, and it's causing a systemic infection, and it's causing an entire body reaction. That's what this dude had. You can have subphrenic abscesses, which you have these big abscesses in the abdomen. It can cause pancreatitis. Pancreatitis is also super duper painful, and we like our pancreas for many, many reasons. It can cause cirrhosis of the liver. It can cause fistulas. It can cause, if that gallbladder ruptures, it will lead to an entire peritonitis, which is an entire inflammation of the entire abdomen, and it will, like, people die from peritonitis all the time. Sorry, getting a little excited there. And it can also cause cholelithiasis as well, where that's gallstones where they really should not be. All right, so I am going to bring up one more case study slide, and then I am going to, actually, you know what? I'm going to stop recording here. I'm going to stop sharing. We're going to start with that slide the next time, or for the next chapter. So stay tuned for chapter 2 and more of Jess's, like, way getting really excited about gallstones. But here I am. So here we go. I will see you here for the next chapter in just a second.